Good afternoon, everyone. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I would like to welcome you to today's webinar titled Medicare ACOs Need to Get the Right Benchmarks to be Successful in Risk Pathways ACOs. It will be jointly presented by Enjoin and Health Endeavors. So a few items of note before we get started. Some housekeeping here. First of all the attendees have joined today in listen-only mode, so your mic will already be turned off for you, so you don't need to worry about muting yourself. Secondly, I'd like to let everyone know that the webinar is being recorded, and you will have the opportunity to access and rewatch the session and or share it with colleagues after its conclusion. And a link to the recording will actually be emailed to those who registered, but it'll also be available on the ACO Exhibit Hall website. Finally, during the webinar, you will be able to submit questions to our presenters. So feel free to do so, and we will get to as many of those as possible during the Q&A session at the end. The format's going to be a little bit different. We're going to have two presenters that are going to go back to back, and then we'll do a general Q&A for both of them at the end. So feel free to submit a question at any time throughout. And these questions are also being recorded so that even if we're not able to get to yours today during the allotted time, then one of our presenters will follow up with you via email. All right, so our presenters today is Sonia Trepina, and she's the Director of Ambulatory CDI with Enjoin. And then also David Weidman, he's the Director of Population Health with Health Endeavors. So I believe Mr. Pina will be starting us off. So welcome, Sonia.
Thank you, Garrett. Can you hear me okay?
Loud and clear.
Loud and clear, great. Well, thank you for having me on, and thank you for everyone who has joined the webinar. As Garrett said, we are going to focus on today getting that right benchmark on your journey towards further risk within the pathways ACOs. So if you're on the call, I am thinking that you have been on a journey of shifting risk over the past few years, or many years really. As you know, the shift in risk, we are still to a degree in a fee-for-service payment world, but I'm sure many folks on the phone have moved across this continuum here and are taking on more and more risk. And as of late, as you all realize, now there's the Pathways ACOs, which is, again, bringing all of you into more risk. So as you're doing that, obviously, risk scores and benchmarks are incredibly important, and that's going to be our focus of the session today. So I'd like to start with really talking about what's at the core of risk scores. A lot of people, obviously, when you're within an ACO or other risk-sharing programs, you understand that there's a risk score at the population level, right? That outer layer here. But as you start really getting to the core of all of this, it's important to realize all the different layers and how those different layers are impacting your risk score. So we're going to touch upon these different layers throughout both my presentation and David's presentation. So behind that population risk score, there's obviously a methodology, the risk adjustment methodology, and we're going to touch upon that so that everyone understands what that methodology is and the importance of it. And behind that really are ICD-10 codes. And at the core of it all, which we'll also talk about, is the documentation. And sometimes we forget that the documentation really is so critical because it needs to be accurate, it needs to be compliant, it needs to be specific, it ties to those ICD-10 codes. And if we can get those two layers done, then the methodologies will do the rest of the work to really get you to that right score. Let's talk about the methodology a little bit. Given the time that we have today, I'm not going to go into deep explanation, and feel free to reach out with more questions if you want more detailed explanation on the methodology. But basically, the CMS HCC model, which is used for the pathways and ACO methodologies, is a prospective model. It's using diagnostic information, again, those ICD-10 codes, to really pull together a score for your patients. So it's looking at ICD-10 codes. It's looking at really a lot of chronic conditions, and it's taking those chronic conditions and group them into categories. It's also taking into account demographic variables, and this model is an additive model, meaning as you pick up more of those chronic conditions, they're added together to help you with your risk score number. The model also has a hierarchy component to it, meaning that there are clusters of conditions that are grouped together. Diabetes is a great example. In the diabetes category, there are diabetes HTC 17, 18, and 19. And when you're looking at the hierarchy, there's a trumping effect that goes into play. So the highest weighted HTC is taken into account for your score calculation. And I've mentioned the additive piece. And then the other component of this model are disease interactions, meaning that CMS has looked at, which diseases, when pulled together, really do impact patient care, require more resources, and in those situations have added an additional weight to the score. So let me go into a little bit more detail and give you a scenario of how it all comes together. So on this slide is just a snapshot of the different HCC categories, not all of them, just a few of them. And you can see here that each category has a weight associated with it. And in this example, we're pointing out the HCC 18 at the 0.307, 21, the protein calorie malnutrition, etc. So as we look at the model and how it all adds up, we've talked about the coefficient or the weight. We've talked about the fact that there is a number assigned to demographics. So you can see here in this just example, let's say that a patient's demographics comes out to a 0.73 and they have various HTCs assigned to them, and those add up to 1.073. Then those combined adds up to a 1.803 risk score, which then is used to add to the population and calculate future benchmarking. So how it all adds up in a different view here, so that you can see basically how it ties to dollars. In this example, we have a patient who's 84-year-old female, non-dual aged. You can see at the very top of the box here, there's a score for that demographic category. And for this patient, we say, okay, she's got COPD, she has diabetes with a CKD, she has CKD stage 5 here, and chronic diastolic heart failure. So you can see the weights for all of those conditions. Then you see that it says disease interaction, and you see a couple of those there, actually 3 of them there, that get added to the weight, and a total RAF score is then calculated. You add that or multiply it by a PMPM payment to get an annual payment. So that's the simplest way to explain how risk scores tie to dollars. What's important here on this slide, and I'd like to point out, is when you're in an ACO entity area and you're really working towards improving your risk score, what's really critical here is where you see the blue box and it says provider impact. If we can educate the providers on what is important to pick up appropriately and compliantly, and the impact of that documentation and coding, really that's what needs to happen. These interactions and all these calculations and the demographics gets taken care of in the methodology programming. It's, for those who are in operations and trying to improve scores here, that's really the key, is work on that documentation and that coding piece. So I did want to mention, I talked about the methodology as it is now. For 2020, there is, in addition to the methodology that is coming out, and you can see here, same thing, demographics, health status, but you can see that APCC, that's the alternative payment condition count. So in addition to what's in place now, what's happening is now there will be a count based on how many HCCs a patient has, a beneficiary has. And based on that count, there will be an additional weight added to the patient's score. As you can see here, less than 4 HTCs, there's no weight added to it. When you hit that 4 HTC mark, there's the 0.006 that's added to it, and you can see the deltas there as we go down the chart. So what I wanted to share here is when we think about the concept of the count methodology coming into play, you may think, okay, well, great, that's extra weight. But when I, as just one simple example, took that same patient that we had on the previous slide and now plugged in the numbers, the coefficients for the weights for the non-dual aged patient for 2020. And as you look at this slide compared to the other slide, I've now added the 4 payment HTCs at 0.006. But when you look at the annual payment or the math behind it all, it's actually a lower payment than what it was without that additional layer. And that really speaks to the whole erosion factor. It's really important within the ACO or risk adjustment programs that every year, everyone do the best they can to capture all of the conditions, all of those new chronic conditions, because if you just do the same work that you've done last year, it does not mean that your score will be the same or that it will increase. And this is just, again, one example. I didn't cherry pick it, so it was really interesting to see how it played out. A couple other things for 2020 is that there are some new HCCs being added to the list. You can see them here, the dementia codes, and then an additional HCC to the few pressure ulcer ones that were already there. I'm not going to go into that in detail, but just wanted to mention it to all of you as an FYI. But going back to where we started, with that graph with the circle, documentation really is critical and at the core here, leading to the I-10 codes. So just wanted to remind everyone that as you're speaking and educating your doctors, that you make sure that you let them know that and make sure that they're not just listing the codes in their assessment and plan, but they really are demonstrating how they are monitoring, evaluating, assessing, and treating that patient so that documentation is clear, concise, so that it can be counted and it can be compliant for that code. And then obviously making sure that they can appropriately pick up the code in the EMR and that the EMR is then pulling the information over onto the claims appropriately. So just a reminder there, and then David will touch upon some of this stuff also. So what should you be doing now? Really start engaging your providers if you haven't already, and if you have engaged them, continue to engage them. Let them know about the changes that are coming up, some of those documentation tips, etc. Get them excited about the documentation and the coding. Definitely keep apprised of changes. The ACO exhibit hall is a great resource for everyone. So definitely just keep checking back and seeing what updates and more information is available. I would definitely recommend starting to educate now for the 2020 changes. Absorption takes time. The more people hear something, the better the chance that they will continue to remember it. And it will not hurt at all for providers to start documenting to the level of specificity needed for 2020 so that you can start the year off right. The sooner you get those risk scores or HCCs captured, I should say, the better off you are. And definitely start building those processes to support HCC capture. So with that, I am going to hand it over to David.
All right. Thank you, Sonia. I'm going to make the switch here. One moment, please. All right, David, take it away.
Right. Thank you, Garrett. Thank you, Sonia. So let's talk about how we get the benchmark right. So to start, let's just talk a little bit around what is the benchmark. So really, the benchmark is a dollar amount of annual expected spend for a patient. It's kind of like a quote or an estimate of what is expected to be spent on a patient based on how sick they are or the risk score itself. So the rough formula here, right, as we discussed, is that these HCC categories comprised of diagnoses are calculated with assigned values. This is all factored together with the demographics, and that's going to calculate into the risk score. From there, that's all factored into our financial benchmark. So why this matters? So the risk score, right, is a measure of how sick and costly the patient is now or anticipated to be in future. So the risk score is used to calculate the financial benchmark, right? And that's going to calculate at the provider level, the facility level, the organizational level, and at the patient level. So if the risk score isn't accurate, then your benchmark isn't going to be accurate. So this is a key factor in any value-based care program. So the way we want to look at this, right, is that every diagnosis has an estimated price tag. And what we want to do is we want to fill the cart with all applicable diagnoses. And from there, we're going to bring all of those up and we're going to calculate the risk score and in turn, calculate the benchmark. So what can make the benchmark wrong, right? So diagnoses that are not coded that the patient may have, this is going to reduce your benchmark. So for diagnoses that are coded and maybe the patient doesn't have, this is going to artificially increase your benchmark. For diagnoses that are sent to the payer for inclusion in the benchmark calculation, this could reduce your benchmark. And for diagnoses that are not recoded when they're recurring every 12 months, right, as the benchmark is calculated every year, could reduce the benchmark. And then lastly, as we touched on, diagnosis specificity. So let's take a look at an example here of a decreased score in terms of how this factors into the benchmark. So we have a male, 76, with diabetes, morbid obesity, CHF, and an amputation. This would result in a risk score of 1.973 with an expected annual expenditure of $17,856. And by not coding that amputation status and the morbid obesity, this is essentially going to lower our risk score down to 1.112, which drops the benchmark to $10,064. Roughly, I mean, that's a $800 drop in term, or I'm sorry, a $7,000 drop in terms of that patient's benchmark, right? So what is in our control in all of this? Ultimately, the diagnoses are. The provider team can't influence the age or gender of a patient or any of those demographics factors. So the only real impact a provider team might have is accurate documentation of the patient's health status by billing the proper ICD-10 codes. So how do we get the benchmark right? It all starts with the point of care workflow, and that'll be HCC coding at the point of care and aiming for a recapture rate of 85%. And increasing clinical encounters so that we can do that HCC coding at the point of care. And from there, aiming for a target of 85% completion of annual wellness visits. Next on the list would be looking at a coding audit to verify that the EHR and billing systems are sending all the diagnoses. And then using some of the actionable intelligence we provide for risk scores, benchmarks, the recapture rates, and then predicting benchmarks and who may exceed them in future to support those three items that we just discussed. So first and foremost, right, at the point of care, implementing a workflow so that we can recode diagnoses. And what you'll see here is an example of our tool where we're able to display out the 2019 versus 2018 HCC diagnoses. And we can see cirrhosis of the liver, coagulation defects, morbid obesity. These items all have strike-throughs, meaning that they haven't billed, or they haven't been billed in the current year. We see them in 2018, but we see them dropping off this year, and they could be key factors in that patient's risk score. So as I noted, HCC coding at the point of care really starts with recoding. making sure that all of those diagnoses are still applicable, and then verifying any new applicable diagnoses are coded at that visit, and then putting a care plan in place for the patient to manage those applicable diagnoses. So let's talk for a moment about the EHR intelligence tool here. So this is an example of a Cerner product here in which we were able to connect our tool into through the use of APIs, where now we're able to bring in those HCC conditions and really put them up in front and center at the point of care during the visit. You'll note in this example, it looks like diabetes without complication hasn't been billed, but now the provider team knows that. They're able to open that patient within the EMR. They're able to see what has been billed, not necessarily just within their four walls within the EMR, but all visits, all claims data, and they're able to see all diagnoses. So again, now that provider team has access to those diagnoses, and they're able to make that determination of what should be rebilled and what is being managed. Not only do we display the diagnoses, but we also display the patient's risk score, benchmarks, their spend. And in this example, we can see that this patient requires some attention here because their spend is greater than what we would expect. And the provider team instantly knows that they have exceeded their financial benchmark. And with that being said, one of the first items that any provider team should look at in this instance is whether or not all the codes are being sent, are being captured, are being rebilled along the way. Is this influencing that patient's benchmark? And do we need to recode these items so that we remain a relatively steady benchmark? Now, as I noted, we can connect this into the EHR through the use of APIs, but we also have a patient database search, which is web-based. So for any EMR that cannot make the connection today or is in process, we can still implement this workflow by allowing access to the web-based tool where the provider team can go out, search for that patient, and they're able to pull up those list of diagnoses and have that information with them at the point of care. Now, I'll note, implementing a workflow like this is kind of a long haul. It's going to take at least 12 months to get started. But I think, as we all know with pathways, with the risk adjustments that are coming under this program, probably the most important thing that we're seeing is that there is no downside cap to negative adjustments that can be made to your benchmark. So if you're not doing this today, you should get started immediately at minimum to protect yourself from that no downside cap. So from here, let's talk a little bit about the recapture rate. Now, it's great to compare HCC scores year over year, but I think as Sonia had mentioned in her presentation, there's a bit of an erosion factor. We have new diagnoses that are being added. There are changes to the program. So really comparing year over year doesn't really tell us if the provider team is doing their piece in ensuring that the diagnoses are being recaptured year over year. So what we do is we take and pare down the 80 or so HCC categories down into, I believe it's roughly 60 that all relate to chronic conditions, and we ensure that they're being recaptured year over year. And we set a goal for all of our providers, our organizations, of 85% in terms of a recapture rate. So you'll see just a snippet from the tool here where it shows the recapture rate. Anything in red will indicate very quickly to administration, anybody that may be involved in monitoring these items, that they haven't met that 85% goal. Once they've met the 85%, that will switch over into green. Now, in terms of how do we get patients in, how do we get these diagnoses rebilled, annual wellness visits are probably the most important visit that we can bill out, where we can bring the patient in, have some time to clean up their chart, assess the diagnoses, and rebill anything that we may have missed previously. Most of the groups that we work with see about a 43% completion rate of annual wellness visits. And this is a number of different factors. What we see most commonly is that they have case managers. These groups, practices, organizations may have case managers that are calling, trying to get a hold of patients and scheduling them. And 9 times out of 10, the patients just aren't answering. So we're able to actually now alert the patient by a text notification and say, we see you're overdue for an annual wellness visit, and push that patient back to their primary care provider to schedule. Now, our experience has been that 95% of these text alerts are opened within 2 minutes, and we see a scheduling rate of roughly 83% based on those alerts. So very impactful. Now, let's talk a little bit about why the patient might exceed their benchmark. Largely, this is going to be due to unmanaged conditions, ED visits, readmissions, post-acute care, unexpected trauma. But really, what's in our control here? I'd say unmanaged conditions are. We do have some control in terms of ED visits and potentially with readmissions. Some of the post-acute care, depending upon how you interact with those facilities, you may or may not. The unexpected trauma, that's just going to happen. That's pretty much out of our control. So let's focus on the unmanaged conditions and then talk a little bit about that. And so I think as Sonia alluded to earlier with MEAT, right, this is really what we should start with. Monitoring signs and symptoms, the disease processes. From there, we want to evaluate test results, medications, patient response to treatment, and then we want to assess in ordering tests, patient education, reviewing records, counseling the patient and their family members. We also want to treat with meds, therapies, procedures, modality, and that all starts with this, an interactive health history form. Not just what we're managing within our EHR, but let's be aware of everything else that's going on outside of our four walls. So we're able to send this out to the patient, where the patient now can go out, take a look at every diagnosis that has been billed within their data, and they're able to mark what they're managing, what they're not managing, what they are aware of, what they're unaware of, and also with their medications, what they are taking, what they may not be taking, and all of the reasons why. And let's start that conversation there. From there, we can start sending patients text alerts for care gaps as related to disease, wellness, quality, and medications. So a diabetic can get a text alert that they haven't had an A1C in 9 months or a year and a half, whatever that may be, so that hopefully we're able to push that patient to get those items scheduled and keep them compliant, right? So, as I noted within the get the right benchmark strategy here, we've kind of discussed the patient history. We've discussed increasing clinic encounters. We've talked a little bit about some of that actionable intelligence, but we'll come back to some of that. But really, let's focus on capturing the HCC diagnosis code with the payer, right? So what we found is about 50% of the ACOs that we work with have issues when it comes to sending the claim to Medicare and whether or not the applicable diagnosis codes are being billed. Sometimes we found that there may be a billing system that knows that only a few codes need to be billed in order to get the visit paid, and so they drop them. We've seen other instances where some of the technology that supports their billing functions has a limit or a default setting on how many codes can be billed. And so while the team may be putting 7, 8, 9 codes on a single bill, only 2 or 3, 5, whatever that number may be, are actually being sent. And as a result, not all codes are being captured by the payer and resulting in a lower benchmark. Now, commonly we get asked, specifically with Medicare, is there a limit to the number of ICD codes that can be billed? Now, you can have up to 4 on a service line, and you can include, I believe, up to 12 codes on a single claim, but only those 4 are going to be related to a specific CPT code. Now, to take this a step further, once we have put the workflows in place, put the actionable intelligence in place, once we have done our coding audit here, we can start moving to our analysis piece, right? And we can start tracking and monitoring to ensure that we are successful in our coding efforts. And what this starts is by tracking risk scores and associated benchmarks. From there, we'll want to look at recapture rates to make sure that our teams are actually working within the provided workflows. And then lastly, we can start using some predictive analysis at this point to determine who is going to exceed that benchmark, not only at the patient level, but again, at the provider level, at the facility level, at the organizational level, right? So within our tool, one of the things that we have is our executive dashboard. This is especially important when looking at a panel of patients by provider, by TIN, by organization. And what we look for here is, the recapture rate, the benchmark prediction. There's a number of different factors, but those are the two probably most important that pertain to what we're talking around today. And we can see that every single one of these providers across the list hasn't met their recapture rate. We see that very, very quickly as they're all in red. And I can see very quickly in that second column that we have one provider in particular that looks as if they're going to exceed their benchmark by the end of the year. So this is an invaluable tool for tracking these items along the way. Next, we have our patient master dashboard, where we're able to view these things now on a per patient level. We can see in this example, this test patient of Willie, right? His benchmark looks like he spent 121% of the benchmark so far this year, so he is exceeding it. And we can see the fluctuation in his HCC score year over year, 0.432 to a 1.265, down to a 0.699, back up to a 2.162. I don't really have enough information for me to be able to fully assess this patient, but at a glance, what it appears to me is that with the fluctuations in the benchmark, most likely this individual had some conditions that they weren't managing. Most likely the provider team wasn't managing either. In 2017, we saw, a higher score in 2016, and it appears that things dropped off pretty drastically there in 2017, and then shot back up in the 2018 year. So most likely this individual could have had a catastrophic event that led to additional conditions. And as a result, we would expect with some of those catastrophic events and unmanaged conditions that they're going to exceed their benchmark, just like we're seeing here. Now, this is all hypothetical. We could dig into the data, but just at a glance, that's kind of the connection that I might make there. So to kind of recap, right, within our strategy here, start with the patient history, implementing that HCC coding at the point of care, right? That really needs to be embedded in the workflow, and setting that goal of the 85% recapture rate, and communicating that to the providers. And communication is key. And then increasing those clinic encounters, right? So that we can continue with the HCC coding at the point of care, and then increasing the annual wellness visit rate to 85%. From there, we can conduct the audit, right? Where we're able to determine whether or not all diagnosis codes are being sent to the payer and factored into our benchmark. And then using some of that actionable intelligence to support all of our initiatives, right? So that we're able to track risk scores and benchmarks. We're able to see who's going to exceed their benchmark, who's compliant with the recapture goal of 85%, and then texting our patients so that they can get in for those wellness visits and manage any of those chronic diseases that they may have along the way. So with that being said, I'm going to go ahead and turn this back over to Garrett.
All right. Well, thank you both. You did an excellent job with the presentations, very clear. And we do have a question that I wanted to pose. And I think this is for Sonia, but I think both of you could probably speak to it. I said, you mentioned the importance of engaging our physicians. Are there any best practices to do that using your system?
Sure, I can start. I would say a great first step is to start with peer-to-peer education. What we've seen work with our clients is starting off with general awareness education for those who maybe don't even understand, the importance of HCCs and risk adjustment, making sure it is a provider, educating providers, and we are physician-owned, physician-directed, and that is part of how we help our clients. From there, once you start building that awareness, I would say to start providing more detailed education, and that would be around focused groups, PCPs, cardiologists, etc. I would highly recommend that when you are educating from a focus perspective, that you use your analytics from your facility, your organization, and even chart reviews. We found chart reviews to be incredibly valuable in being able to take that information and then share it with the provider and say, this is from your organization. Here's where we are seeing gaps, and here's what you need to be doing in your documentation and coding. So those are a couple of things to start with.
Okay, great. David, did you have anything that you wanted to add to that one?
Well, I might add, ensuring that you also have some technology to support your physicians in any of these initiatives. I think that's very important when it comes to provider engagement. As Sonia was saying, you've really got to start with the educational piece, provider buy-in. But our experience has been, especially with provider buy-in, at least the provider understanding the long-term payoff and the tools that are available to help them to be successful, and ensuring that you're not bogging down their current workflows, or you're not adding a number of different items that they may perceive as manual. And if you're able to support them with technology and really make this as simplistic and easy as possible, I think that really assists in terms of the provider buy-in.
Okay, great. Are there any other questions? I think that was the only one that came through. If anyone is trying to send a question, you have to open up your panel and submit it through there. But unless it comes through in the next couple seconds, we'll go ahead and conclude because we are running up on time anyway. And so thank you so much again, Sonia and David. We really appreciated the presentation. It was very in-depth and informative. And again, if you do have any questions that you maybe weren't able to figure out how to submit today, we will get back to you, or they will get back to you via email, and they'll be happy to follow up with you for further discussion. Lastly, wanted to encourage you all to be sure to visit the Enjoin and the Health Endeavors exhibit booths at acoexhibithall.com, which you'll see on the screen is the link. And that way you can connect with their team and learn more about them and what they're offering. And the recording of this presentation will be also available in the reference library under webinars category in the acoexhibithall.com library. So that said, thank you all so much for attending. I hope you found today's presentation very informative and helpful, and hope you have a great rest of your day. Thanks for coming.